Leslie, how are we doing with our numbers?
We are getting ready to start. Okay, so
I'll call the
we
meeting
have a quorum.
Okay, so we'll call the meeting to order. Could we have welcome to everybody again?
Just a second, Chair Khan, just a second. I have to start.
Are we still in practice session?
I just started. Okay.
All right, thank you. So we'll call the meeting to order. And let's take the roll call, please, Leslie.
Okay, hang on. People are still signing on here. Good morning, everybody.
Morning.
The chair has just called the meeting to order. So I'm going to take roll. Batt Bond.
Here.
Lenitra Grady.
Go ahead.
Lenitra Grady, I see you there, but you have to unmute.
Good morning. I'm here.
Good morning. Flo Khan.
Here.
Chair Khan.
Present.
Leanne McAllister.
I'm here.
Yarleni Roa Dugan.
Here.
And all right, we have our vice chair, Sandy Rubalid.
Here.
Beth Slamowitz.
Present.
Tiffany Tyler Gardner.
Present. Good morning.
Good morning. Mason Van Howling.
Morning, everyone.
Tyler Winkler.
Here, present.
And then we have our non-voting members, Ryan High,
Present.
Laura Rich,
I'm here.
Barbara Richardson.
Morning.
Good morning. Richard Whitley.
Here.
Good morning. Chair, we have a quorum.
Thank you, Leslie. The next item on the agenda is approval of minutes. I presume everybody got them and had the opportunity to read them. So I would present that for a motion to approve the minutes.
To make a motion, Chair.
Is there a second?
Second, Chair.
Second. Any opposed? None. Motion carries. So the next item on the agenda is public comment. We usually have
Chair
3
Khan.
minutes. Yes.
I apologize. Can we go back to agenda item number 2, please?
Yes, we're
Oh.
introducing our new
Yes, yes,
executive
yes.
director.
How could I forget that? I've been talking to her all morning. So, introduction of our new PBC Executive Director, Melinda Sazad. Are you here? We can see you all.
Yes, thank you so much. I just
Welcome.
had
Tell us a little bit about yourself.
absolutely happy to. So good morning, everybody. I basically wanted to start with where I grew up, because that always helps to get to know somebody. So I grew up in Amador County, California, in the middle of a forest with a very active and outdoor childhood. And when I was in preschool, I remember the teacher asking us to draw a picture of what we wanted to be when we grew up. And I drew a picture of a nurse. I knew I always wanted to do something to help people. And while I didn't end up becoming a nurse, I still had that helpful persona that's really stayed with me throughout the years. Being a chiropractic physician was extremely rewarding. I really enjoyed teaching others about how their bodies moved and worked and how to do the activities that they love without pain. It's really extraordinary to see somebody come into your office in excruciating pain and be able to work with them and come to the root of the problem, be able to help them, and to see the joy that returns to their life when they're able to do the activities that they love. So Being self-employed as a chiropractor didn't necessarily come with those long-term benefits that you start to think about after you grow up. So I was recently married at the time and starting a family of my own. And I made the difficult decision to retire as a chiropractor and to continue my quest for helping others through a new career with the state of Nevada. I briefly worked at Nevada Medicaid, and then I moved over to the Division of Public and Behavioral Health's Public Health Preparedness Program, where I've served for the past 7 years. In the world of public health emergency preparedness, we all train together, plan together, and exercise together. Exercise not meaning aerobics, but actually acting out scenarios to test our statewide emergency response plans. And we continuously invite participation across all types of state, local, tribal, and federal agencies. So it was really neat to work in that role and to get to collaborate across so many different aspects and partnerships within our state. We all really became friends in that line of work. And I think it's those friendships and relationships that really make our state feel small and close-knit, even though our geography may say otherwise. For the surely challenging road that comes with the tasks that are charged to the PPC, I feel we must collaborate to have a common vision and a shared understanding in order to reach any goal. And I'm really encouraged to see the PPC's mission, vision, and values summed up in this one statement, that the PPC is designed to provide a forum for all stakeholders to come to the table and work together on the critical task of improving healthcare access and affordability in Nevada. That being said, and to help you all get to know me a little better, I'd like to share with you my leadership philosophy, since it's really at the core of everything I do. Strive to be your very best, show respect for others, be accountable in all that you do, and do your best to emulate truth, trust, and positive leadership. I'm a really positive person, and I'm excited to share that with you all. And I really appreciate you all for voluntarily serving on this commission, for the hard work and dedication that you've shown already, and truly committing to improving the healthcare for all Nevadans. I'm absolutely honored to be here with all of you and sincerely look forward to working with each and every one of you to put forward policies improving healthcare within our state. And that's about it for me. So thank you, Chair Khan.
Chair, you're muted.
Welcome, Melinda. Well said.
Thank you, Mason. Agreed.
Yes, welcome.
Thank you.
All right. So now back to our public comment. As I was saying earlier, that public comments are limited to 3 minutes per person. Do we have any public comments from our people in presence in the North Office or South Office?
None that I can see. If you are on the line and you would like to speak, please hit *9. And I'll give you a minute to do that. No, Chair?
Thank you. Did we get any written comments?
No.
All right, thank you. Moving on to the next item, keep track of my items, Leslie. I don't want to miss anything.
We're next up to Michael
Item number,
Batt.
introduction to data use strategy. Michael Bailett.
Thank you, Chair Khan. And
10
hello.
minutes, Michael, you remember from last time, you have 10 minutes. So that includes questions that people might have for this subject.
Yes, thank you. All right, nice to be with you all today. So our first agenda topic is to discuss something called the data use strategy. But before we go there, I just want to orient you in terms of where we are right now. So April 20th, what we're covering today is an introduction to something I'm referring to as the data use strategy, where they're going to have an extended review of findings of Medicaid and PEB cost driver analyses that were recently completed. And then I want to briefly revisit the topic of setting thresholds for public reporting of provider entity performance relative to the benchmark. Okay, so that's today's focus. When we come back to our next meeting in May, we're going to talk about cost growth mitigation strategies for the first time to help ensure that we attain the benchmark. And we're going to talk again about the draft bill requests. Okay, and you can see in between the meetings, we've got time scheduled with the advisory subcommittee. Next slide, please. Okay, so let's talk about the data use strategy. So the next slide you've seen before, but I want to reorient you because it's easy to get confused by the two different types of data analyses that are being performed. So on the left, you can see a description of the benchmark analysis. This is an assessment of what is the change in per capita spending growth year to year. And in doing this measurement, we're assessing whether or not the benchmark was attained. The data for conducting the benchmark analysis comes from payers who submitted an aggregate form. And it allows for assessment at 4 levels: the state level, at the insurance market level, the individual insurer level, and the large provider entity level. Okay, the aggregate data that we get covers all populations and all types of payments. But because it's aggregate, it doesn't allow us to do nuanced analysis to understand what's really driving healthcare spending and spending growth in the state. So its complement is what we call the data use strategy. And the data use strategy is use of claim level data to understand what's happening under the hood and gives us more insight than what we get through the benchmark analysis. So in time, the data source for the data use strategy will be the all payer claims database, but it's not yet developed. So on an interim basis, we are using separate analysis of Medicaid claim data and of PEB claim and payment data. And we are using the PEB claim data as a proxy for the commercial market. Okay, so 2 different types of analyses. Our focus today is going to be on the right side of the slide, the data use strategy. So why pursue it? Well, as I said, we want to understand the factors driving healthcare spending levels and growth. Tiffany, you have a question?
Just a quick clarifying question. And so the data use strategy, that will allow us to do some of the supplemental reports that we talked about, like contextualizing any outliers that we might discover and some of those items?
Yes.
Perfect. Thank you.
Right. Okay, so this allows us to ask lots of detailed questions. And the reason we want to do detailed analysis to truly understand what's driving spending patterns and spending growth especially is so that you all then can identify in a data-informed way strategies that will mitigate future cost growth. Without this type of data analysis, you can't really know what's driving healthcare spending. And so that's why we're doing it. So we refer to these analyses of claim data as a data use strategy because we are measuring and conducting analyses so that we can use the analyses to inform action. Okay, action is the end goal. If all we're doing is measuring and reporting, we're not doing anything to improve affordability. So our end goal is to identify and adopt and implement strategies that will mitigate future spending growth. So there are 2 types of analyses in a data use strategy. The phase 1 analyses are going to be the focus of the presentations you received today. These are standard analyses produced on an annual basis in order to track the patterns of healthcare spending. And again, in the longer term, we want these to be generated out of the all payer claims database. But they're produced on an annual basis so that you, as a commission, can track what's going on in healthcare spending in the state. And you don't just know how much it's growing, but you know where it's growing and why. The phase 2 analyses to be performed in the future will have some additional, more in-depth analyses that supplement the phase 1 analyses. They also include ad hoc drill down analyses. So sometimes when you're going to be presented with data, you're going to ask questions. And you're going to say, I want to know a little bit more. Can we understand this a little bit more deeply? Well, those are the ad hoc drill down analyses that I'm referring to. So the slides that are going to follow are going to provide an overview of the phase 1 analyses so that you can understand strategically what we're trying to do. And then you will actually have them presented to you for Medicaid and PEM. Any questions so far? Okay. So the general framework for the data use strategy is to address 3 questions. Where is spending problematic? What's causing the problem? And then who's accountable? So let me walk through each of these in a little bit of detail just to help frame what you're going to see. And please feel free to raise your hand and ask a question as we go along. So when we look at where spending's problematic, we're interested in where is spending high at a given point in time and or where it's growing at a high rate over time. So we might find that there are some categories of spending that are very high, but they're not growing quickly. Okay, so for example, in a number of states, inpatient hospital spending is high, but it hasn't been growing quickly in a lot of states in recent years. There are other categories that might have a very high rate of growth, however. And those are the ones that are going to be driving up the rate of growth and challenging the ability to meet the cost growth benchmark. You can meet the benchmark in 2 ways. You can reduce spending in a large category, or you can slow spending in a category where growth is quick or fast. 2, we also identify where spending is problematic by looking at variation across geographic regions, payers, and providers. Because where there's variation, usually there are some inefficiencies. They can be a result of inconsistent ways of delivering care, levels of market competition, the composition of the provider market, and perhaps patient population characteristics. Finally, we identify where spending is problematic by comparing Nevada spending to spending in other states. And there are a number of organizations that publish benchmark data that allows us to see what does Nevada look like compared to other states. All right, so this is question number 1, where it's problematic. 2, what's causing the problem? So there are a number of usual suspects when we look at what's driving healthcare spending growth. One is to look at price, and more specifically, the payment amounts for services and how they are changing year over year. Across the United States, the primary driver of healthcare spending growth in the commercial market is price in every single state. 2, we're interested in looking at volume and specifically whether there are more services being utilized, and if so, which services. 3, we're interested in changes in the intensity of care, which is sometimes referred to as service mix. So we're interested in whether, for example, there are fewer X-rays being delivered and more MRIs. That's a change in service intensity from less intensive to more intensive. Okay, or fewer vaginal births and more C-sections, less intensive, more intensive. And there are many, many other examples, including some cited here on the slide.
Quick question.
Yes.
You're talking about volume. Are you talking about overutilization, not just intensity, overutilization of services? Because you see this all the time in the hospitals. Doctors order tests just because. I mean, I'm not saying that lightly. Is that taken into account, overutilization of services?
So that would be a supplemental analysis. Initially, we're just looking at whether volume is growing without knowing whether it's overutilization or appropriate utilization. A follow-up analysis might be to look at delivery of low value care. But initially, we just want to see what's changing year over year. Are prices going up? Are volumes going up? Is service intensity going up? And how does that vary by service and by payer and by market? Okay, then the whys, those are the supplemental questions. So, maybe a why question for volume is, do we have growing amounts of low value care? Okay. The last 2 questions we want to look at are changes in population characteristics Typically, these don't have a big impact on an individual year, but they may over several years. There are also real challenges in measuring them. We've talked about the challenges of measuring clinical risk. There's growing interest in measuring the impact of social risk, which is technically hard to do, but there's a lot of interest in it. And then it's more simple to assess the impact of changes in demographic characteristics. And then finally, although this isn't going to come out of a metric per se, it can be valuable to look at provider supply, because we know that in healthcare, increased supply correlates with increased utilization and spending. Now, that's not always bad utilization and spending, but we know that supply does correlate with utilization and spending. Okay, so these are the variables that we want to examine in a structured way year over year to understand what's driving healthcare spending and spending growth in the state. This is an example, it's actually a few years old now, from the Washington Health Alliance, which is a nonprofit in Washington State. They have a multi-payer claims database, and they looked at a number of services, which you can see in the left column. They looked at changing in PMPM spending over time, and in that gray box, they decomposed the spending growth to identify what was due to demographics or population characteristics, in this case, age, gender, what was due to volume, which is service frequency, what was due to intensity, and what was due to price. And for each of these service categories, they teased out the contribution. And then at the bottom, you can see they summarize what was driving spending for these services during this 1 year time period. 65% was due to price, 18% was due to volume, and the remainder was changes in population demographics and service intensity. This type of analysis helps you understand why spending is growing, and then helps you as a commission identify cost growth mitigation strategies to slow spending growth and improve affordability. So the last question is, who is accountable? And this is about the level at which analyses are performed. So there are many options in terms of deconstructing spending. At the state level, we can look at it through geographic definitions. Within the insurance market, we have commercial, Medicaid, and Medicare. Within commercial, there's fully insured and self-insured, and then the marketplace. Medicaid in Nevada has both a managed care and a fee-for-service component. And in Medicare, we've got the managed Medicare Advantage products and traditional or fee-for-service Medicare. We can look at individual payers, including by product, and then look at provider entities. So in our measurement of benchmark performance of provider entities, we're looking at very large groups and health systems. But when we're using claim data, we have the ability to look at smaller units of analysis. So we could look at individual hospitals, for example, or individual large orthopedic practices, for example, in a way that we would never do in the benchmark analysis because of the way the measurement's being performed there. Right, so, yep, go ahead.
A quick comment. So how would one break down, for example, in a hospital, the doctor is responsible for the utilization of services, how many, too many expensive services, et cetera, et cetera. So how does one assign it to a physician like hospitalists or specialists?
Well, there are myriad ways. It depends what you want to look at. If there's a concern that there's a particular procedure that's performed in much greater frequency at one hospital than at another, then analysis of claim data would allow you to shine a light on that and say, wow, this is a source of variation that seems beyond the norm. This is something worth engaging both the physicians and the hospital in reviewing.
So I guess my question would be that, you see, the hospitals, for example, if they are on a contractual basis with insurance companies or on a DRG, they would not be interested in overutilization of services. But the doctor who's ordering the services based on practice habits and patterns, that is what drives the cost of that service within the hospital. And that is not captured towards or assigned towards the physician, who then should be held accountable for those services.
Well, it could be. I don't know that you're going to get into this level of detail, but you could say, wow, we've got a hospital that's performing procedure X 75% more often than any other hospital in the state. So let's look at who are the physicians performing the services at that hospital.
Okay, that somewhere down the road, that's worth looking into.
Mm-hmm.
Thank you.
Okay, sure, thank you. Stacy, next slide. Thanks. So we recommend states begin with 11 standard reports. The reports should have some common characteristics. They should break down price, volume, population characteristics, and service intensity to understand what's driving spending growth. They should have multiple years of data. We said a minimum of 2, but you'll see here both analyses that were performed had many more than 2, which is great. They should look at spending both on a total basis and on a per capita basis. They should be released minimally at a time to complement public reporting of performance against the cost growth benchmark, so that when you report out cost growth benchmark results, you can also report supplemental data that explains what's happening, again, under the hood with the benchmark performance. That doesn't mean it's the only time it would be reported, but that would be one time. So these are the 11 phase 1 analyses, and the next slide shows the ones that initially were identified for development or production by Medicaid and PEP. And this again is what you're going to see shortly today. Next slide. So the initial reports you're going to see are going to have multiple years of performance. They are only at the state and market levels. You're not going to see any provider or insurer level data today. Tiffany.
I have a question about the 2 previous slides, particularly the slide highlighting which initial data points or elements were selected. The ones in bold, I'm assuming, are the ones that were selected and the others are not. Is that the case?
Yeah, I think the others will follow, just not in what you're going to see in the first batch today.
So it's not that we won't at some point look at the span and trend by health condition, recognizing the importance of that. It's just not what we're starting with.
Right.
Is that the case? Okay.
Yeah, but that is to come. Okay, I see another hand raised. Tyler.
There. I had kind of asked this in an email about, because I know what we're looking at is just claims-based payments, but before we actually get to all the data we're going to collect from all payers, will we evaluate all the other categories of spending and non-claims-based spending of just our PEB and Medicaid before then?
No, we're just going to get that through the benchmark measurement. Okay. Because it's not captured in the same database, Tyler.
Okay.
But as you're going to hear later on, we are about to request data for the benchmark for the pre-benchmark period, and we will be gathering all of that non-claims-based spending.
Great.
Yeah, and we'll be able to tell you definitively what percentage of spending is non-claims-based, and how does that vary by market in the state, at least over the last few years. Thanks for your question. Stacy? All right, so the phase 2 analyses can include a number of supplemental reports. So you can see number 1 envisions drilling down to provider entity and payer level analyses, which haven't been done yet. There's the opportunity for focusing in some other areas, for example, a deeper dive into pharmacy, which is an area of high spending growth and is a little bit complex to measure because it involves both retail pharmacy and also what we refer to as medical pharmacy, which are physician administered drugs. There is an opportunity to look at particular physician specialties. Chair Khan, that's a little bit what you were getting at. And there's ability number 6 to look at out-of-pocket spending, so that in addition to looking at what's happening with total spending, we can see what our consumers experiencing. Right. So these are some options for phase 2, which will follow later this year.
Michael, I have a question on that. In terms of that out-of-pocket spending, is that a relatively new category that has been captured?
So I know of at least one other cost growth benchmark state, actually two that have measured out-of-pocket spending. And what they found is that out-of-pocket spending growth, particularly in the commercial market, because that's where there's the most, has for several years grown faster than total spending growth. And that reflects changes in benefit design and employee selection of benefit design, which is usually a reaction to high and growing premiums.
Okay. Yep. Thank you. I think that's helpful.
Leanne?
And is out-of-pocket costs just deductibles and copays, or does it also cover premiums?
So it's just deductibles, copays, and coinsurance. But you're right. I mean, ultimately, the out-of-pocket costs for consumers include premiums as well. Okay, next slide. So there are many analyses that can be performed. And in fact, because analytic resources are expensive and scarce, it's important to be really strategic and selective in deciding what to pursue. But ultimately, in doing this work, I think it's important that whatever is reported to public bodies like you is simple and easy to understand. That there should be transparency about the analytic methodology so everyone understands how the calculations were performed. And when reporting on individual payer and provider performance, there's an opportunity for those entities to review their data before it's published. So those are just some general recommended guidelines for this type of work. So let me wrap up by just telling you what's to come. The phase 1 reports you're going to receive today. The phase 2 reports are going to be reported to you during or after July. And these will include more complex analyses that supplement what you're receiving today. The benchmark reporting is going to happen in early 2023. And here we're going to look at healthcare spending growth between 2018 and 2021 using payer reported aggregate data. For these initial reports, the reporting will be at the state and market level. It will not be at the insurer provider entity level. That will occur in the reporting in 2024.
Does that wrap it up?
That wraps it up, unless there are any further questions.
Yeah, any questions from any commissioners?
Michael, one more question that I had on that previous slide with respect to the timing. You mentioned that as you get into that kind of those supplemental reports, how much time is going to be allotted for, the payers and others to look at the data, review the data, and see where kind of basically understand and make sure the data is accurate?
So the phase 2 analyses, if anything is done at the payer provider level, they'll get an opportunity to see it in advance. Okay, so if they look at it and they say, this can't possibly be right, they'll have a chance to say that. Generally, data that are at a more aggregate level are not shared for review in advance. Okay, although certainly there needs to be on the state side some careful vetting of the information to make sure that it's correct. But generally, the practice is only to share information with individual payers and providers when they are named.
Okay, got it.
All right, if no more questions, we'll wrap this subject up. Go to the next item, number 6, review and discussion of findings of Medicaid Phase 1 cost driver analyses. We have Kyra Morgan, Chief Biostatistician for the Nevada State. So do we have Kyra Morgan on here?
Yes, I'm on the line. Can you guys hear me okay? Okay.
Yes.
Yeah, so you have 40 minutes. I hope you're all sensitive to the time of the commissioners.
Okay, I'm going to go fast. Just thank you for the introduction. I'm Kyra Morgan. I'm the state biostatistician for the Department of Health and Human Services. And as you know, I'm going to talk about the cost driver analysis that Michael just went over for us. So I thought it was important first to include a slide here with a little bit of background information on Nevada Medicaid, just because I wasn't sure if the audience was really oriented to the scope of Nevada Medicaid. So we are the largest provider of health insurance in Nevada, covering about 1 in 4 Nevadans. We've had really significant year-over-year caseload growth. Lately, from 2020 to 2021, we grew by 33.5%, or we now cover more than 215,000 additional Nevadans in 2021. And then in any given month, about 40% of our members utilize healthcare. Next slide, please. Thank you. So the purpose of this, again, and I won't go into this in detail, but really is to just monitor per member per month healthcare costs and growth in Nevada's Medicaid population, and to serve as a starting point for understanding cost drivers and spending patterns in Nevada Medicaid. And as Michael said, the goal is to spark questions from you all, and then in phase 2, we can do deeper dives. So what I'm going to go over today is actually very high level. I did include some terms and definitions on this slide, mainly for your reference later. But most importantly, I just want to make sure everyone is familiar with and oriented to this idea of per member per month, or PMPM spend, which is just monthly spend divided by enrollment, and then we average that out to get annual numbers. And realizing that this is a little bit oversimplified, we really can consider increases to per member per month spend as a factor of 2 things. One being utilization, how many things are we paying for? The other being unit cost, what are we paying for them? And so throughout the analysis, as we identify trends in PMPMs, we'll dig deeper into whether we think that's driven by utilization or spend per utilizer. And sometimes it's driven by a little bit of both. Next slide, please.
Chair, could I just ask Kyra one question? I'm sorry to interrupt you, Kyra.
Yeah.
This is Batt. The data that you just went over, is that in this deck somewhere? I'm trying to speed through the deck and don't see it. The 40% utilization by somebody and the number of lives that you cover, and you had 2 more statistics. I just want to make sure we capture those.
Yes, in the larger slide deck, it's on slide 23.
Okay, thank you.
Yes. So this slide just touches high level on methodology. So we rely on Medicaid claims data and encounters from our data warehouse. We're looking at claims incurred from 2016 to 2020. You'll notice that I am quantifying cost growth using an average year-over-year trend. And in that trend, we actually decided to exclude 2020 and base our baseline analysis on 2016 through 2019. The reason for that is because Medicaid had really atypical caseload growth because of the pandemic. We also had really atypical utilization because of the pandemic. And so we just saw that we thought it would be more realistic to create a baseline on pre-pandemic data. And then we'll see kind of the impact of 2020 and 2021 as we expand this in future years. So here you'll see a table.
A quick question, sorry, I didn't mean to interrupt you. So when you say claims data, I'm presuming that the claims paid data, I mean, the claims could be 100,000, but nobody's getting paid 100,000, whatever the negotiated rate is. So you're going by that paid claims data.
That's correct, right. Yes.
Okay.
Wait, is that true for drugs as well for the pharmacy? So that includes rebates?
That's correct.
Okay, thank you.
Okay, so in this table here, you'll just see the different levels for which we're going to stratify the data in the following slides. So we break it down by plan type, where we consider fee-for-service versus managed care. Service categories to include inpatient and outpatient, hospital, professional, long-term care, dental, and pharmacy. Again, we do incorporate an estimated rebate is taken kind of off the top of our pharmaceutical numbers here. And then we include geography, where we consider North to be Washoe and Carson City, south to be Clark County, and rurals are any other county not named there. And then we'll touch at a high level on age and gender. Next slide, please. So this is at a high level in general. Our findings are that Nevada Medicaid has experienced an average year-over-year trend of 5.5% growth from 2016 to 2019. The largest increase year-over-year was from 18 to 19. And then kind of as expected, our per member per month cost decreased in 2020. We're attributing that to a combination of increased enrollment, which feeds into your denominator, and then decreased utilization, again, largely driven by the pandemic. Next slide, please. Here we're
I'll add that every other state also had negative trend in 2020.
Here we're breaking it down by fee for service and managed care. And when we segment that out, we do see that growing healthcare costs are present across both plans, about 9% year over year in managed care and 6% year over year in fee for service. Obviously, what's also apparent on this slide is that our fee for service plan is significantly more costly than managed care on a per member level, although it only contributes to about 30% of our membership. And the high cost in that population really is driven by individuals who are eligible for Medicaid under a specific eligibility category, which is the age, blind, and disabled population. That population falls under exclusively fee for service. We don't have those individuals in our managed care plans, and so they drive up our fee for service costs pretty significantly.
So just, and you brought it up, the fee for service population is considered sicker with more complex medical diagnoses, and therefore is expected to have higher, cost. But managed care cost is also 9%. How does that explanation come? Why are they, when they're technically or theoretically, not theoretically, actually, selected or not cherry-picked is not the right word, but they have the lesser sicker population, not that they're not sick. So why is their cost also going up just as the other fee for service?
Right, that's a good question. I think the goal today is to start we're just going to scratch the surface, frankly, today, but I think the goal is to start really digging away at that. So in Michael's presentation, he talked about, there's kind of two components. There's areas that are more expensive, but maybe aren't growing as quickly in cost. And then there's areas that are growing very quickly in cost. And so in my next slide, and we can actually progress to the next slide, I break this down by utilization and spend per utilizer to try to do just that. I don't think it gets all the way there because what you see in the chart to the left, just to orient you, the small dotted lines are referring to spend per utilizer. The larger dashed lines are representing changes in utilization. Green is managed care and blue is fee for service. So you can see managed care is experiencing growth in both utilization and cost per utilizer significantly. So 8% year over year growth in spend per utilizer paired with 6% year over year growth in utilization. Whereas our fee for service population is expensive. So they're growing by 5% year over year in spend per utilizer, but utilization is not actually up. And then on the next slide, I felt that we should pull out those high cost, high risk folks from the fee for service population. So you could kind of see what it looks like if it wasn't driven so much by the age, blind, and disabled. So here, you can see it's an entirely different trend. In the fee for service, our per member per month costs are actually not growing over time. I mean, they grew from 2016 to 17 and then have kind of trended down and had some stability. So in the bottom right, you can see if you take fee for service, excluding age, blind, and disabled, we actually don't identify cost growth in that population on a per member level. The little blurb at the bottom right-hand side shows the PMPM specifically for the age, blind, and disabled, and it's upwards of $1,700 a month. So they are largely driving that particular category.
So my quick question, sorry, I hope I didn't interrupt you. The cost of fee for service, which we have already talked about, it seems that it's not going up too much. My way of thinking is it's being managed better by the state directly to contain the costs, whereas the managed Medicaid, by implication, is perhaps not managing as well to keep their costs down. because both are managed. One is managed by the state, and they are keeping controls on the growth, whereas the other side is managed by private sector, and their costs are going up. They're supposed to be managing much better, and that's why we have them, that they're supposed to save money for the state. Is that correct?
I'm following your logic. I don't feel that I can jump into that conclusion yet. I think we need to drill down a little bit more. The one thing that I would just add to that is that while the managed care costs are growing, they're still under the fee-for-service costs on a per member basis. So they are still, our fee-for-service population is still, disproportionately more expensive per member per month.
Kyra, to follow up on Dr. Khan's comments, and I don't want to get ahead of you here. I think
All right,
I think there's things in the MCO contracts that we don't really understand that well, and I don't know if they impact. I don't know if the administrative load on those contracts or the revenue on those contracts is being fed into this PMPM at all. And maybe that you're going to get there, but I wonder about that extra load that those contracts would have that a regular fee-for-service provider wouldn't have.
And
yeah, that's a very good question. Yep.
Yes, that's a good point, and that is not taken into account here in this analysis. This is exclusively claims data.
Okay.
Kyra, Tiffany Tyler Garner has a question. She has her hand up, and then so does Flo Khan. So Tiffany.
Thank you. I just had a quick clarifying question. In terms of fee for service, I know that you've presented year over year here for us, but can you tell us what the percentage of growth was over that 5-year period for fee for service? Like, I'm thinking about the slide where I believe it was like 680 something in that first year of analysis, and then 5 years later it was over $800.
Yeah, I don't have that hand. I mean, I have it calculated, but I just don't have it in front of me. If I could follow up with you after, and it's this presentation is summarizing a larger report that we made available at the beginning of this month. And so all of that more detailed information is in that larger report. I'll make sure to follow up with you specifically on that number and also with the link to that so you know where to find it. And then I have one more question.
Yeah, Kyra, you said you talked about the age blind and disabled really driving up the cost. What percentage is that of that fee-for-service population?
That's another one I don't know off the top of my head. I'll follow up after the meeting with that exactly.
Okay, no problem. Thank you.
Okay, next slide, please. So now I'm going to jump into service category, and I just want to apologize if I'm going too fast. I'm trying to be thoughtful of the time allotted, so tell me to slow down if I'm going too fast. So here we're breaking it down again into inpatient, outpatient, long-term care, professional, dental, and pharmacy. I see you, Tyler. Do you want to go now, or do you want me to talk about this slide first?
Sorry, really quick, just, no. Sorry, I won't interrupt you. Apologize. I'll wait.
Okay, I'm gonna is it Dr. Khan or Flo? I don't know how you want me to refer. Do you want to jump in here?
No, you're good. I'll have you finish, and then I do have a question on this slide.
Okay, thank you. So what we see is that professional costs are driving our PMPM from the perspective that they are the highest proportion of PMPM spend. That's due to high utilization. Those professional services are not bringing in a high cost per service. We just have a ton of utilization in that category. Inpatient hospitalizations and long-term care are also significant portions of that PMPM spend. Those are due to high cost per service rather than high utilization. And then similarly to what Michael talked about in other states, we actually saw the lowest level of growth in our inpatient and professional categories. So they are the most expensive categories, but they are growing, the cost is growing slower. Whereas I would draw your attention to pharmacy, where we average 15% cost growth year over year on a per member level, 8% in long-term care, and 6% in outpatient. For lack of a better term, I want you to ignore dental on this slide, because we know that the increases in cost there were due to policy changes, and that's not in any way to be extrapolated into an actual price increase. And so it's not entirely useful. So I probably should have maybe taken that out, but don't put a lot of weight in that 46% increase in dental. Next slide, please.
Whoa. We have
Oh,
questions
sorry.
on that. That's
Okay.
okay. So let's go, because I am very interested in the pharmacy section. Can you explain the significant jump between that 2018 to 2019 number? Because that's significant and it does not follow national trends. So why in Nevada would you have that large of a jump when we're not seeing that nationally?
That's another one I'm going to have to take a note. And these are great questions because this is really going to guide our phase 2 reports. And so what I'm going to do today is write all these down and make sure that we actually address all of these in a follow-up.
Okay.
I think I need to probably consult with Medicaid policy staff on that one.
Okay, thank you. Because that is a significant change. And, you know, we would want to drill down, and you can understand perhaps that in like a 2014 when you had a new product come on market, but there was no new product that came onto market in 2018, between 2018 and 2019. And that's significant. So we need to understand why that is. Thank you.
I think Tyler was next.
Thank you. And I'm sorry for interrupting earlier. I know on our benchmark, we have professional services broken down by primary care and specialists. Do we know that at this point?
We don't, but it's on our list of phase 2.
Okay, great.
And Batt.
I'm going to hold. Sorry.
Okay. The next slide here is also related to service categories. So again, just trying to break the information down from the previous slide into distinction between utilization and cost of service increases. So just to kind of orient you to this graph, the numbers in the first column that are bolded are the same exact numbers from the previous slide. Then to the right, you will see changes in utilization that are contributing to that, as well as changes in cost per visit or, you know, cost per prescription for pharmacies claims in the second column. So to drill down a little bit further specific to pharmacy, we see that the cost per is the unit cost is driving that more than utilization. That's the pattern across the board. I would say the takeaway throughout my presentation is going to be that cost is driving our growth and spend more than utilization is. One thing I wanted to also draw your attention to on this slide and really just kind of plant the seed, because I do need to provide more information, is we also include here the percent change from 2019 to 2020, even though we did not include it in our baseline cost growth measurement. The reason I think it's important to highlight here is because the increases in cost per visit from 2019 to 2020 are even greater than the increases that we observed on average from 2016 to 2019. So the PMPM is lower in 2020 because we have low utilization and we have super inflated enrollment. But if we see Nevada Medicaid kind of return to pre-pandemic utilization and pre-pandemic enrollment numbers, and we maintain this cost per visit, it's very possible that the next round of analyses, when we include 2020 and 2021, are going to show a much higher annual year-over-year cost growth. So I just want the audience to kind of be aware of that, even though we're not including 2020 here. I would probably assume, but you know, correct me if I'm wrong, I would probably assume the cost per visit is not going to go down. And so, you know, realistically, that's something that I would just want to have a pulse on as we move forward in these analysis. So just kind of an early warning sign, but we didn't go into that in too much more detail in this conversation. Next slide. So this is a summary by geography. PMPM is highest in Northern Nevada. It's also rising at the fastest rate in Northern Nevada, 8% year over year, whereas the South is 7% year over year, and rural Nevada is growing more slowly. Next slide. Again, just same story here, breaking that down by utilization and spend per utilizer, again, driven primarily by spend per utilizer across the board. We saw utilization actually decline in the north and the rurals slightly, not too significantly, but just small declines. So again, just highlighting that the PMPM increases in geography are driven, as you would imagine, also by spend per utilizer. And then just anchoring to the idea that 77% of our utilization is in the South. So we're heavily tilted that way. Next slide. This is the same information, but by age. You can see that infants less than 1 and older adults over the age of 55 drive the per member per month cost in Nevada Medicaid. Infants have observed the greatest growth, which is 8% year over year in cost. And then that's followed by 6% year over year growth in adults 18 to 54. 5% year-over-year growth in our youth 1 to 17, and then our slowest growth is in our older 55 plus population at 4%. Again, I didn't actually include a breakout on this for the distinction between utilization and cost of service, but we found similarly that this is driven primarily by cost of service increases, most notably in the expensive populations as well, driven by cost of service. And then we did have small increases to utilization in our adult population that those were not present in our infants and youth age 1 to 17. Next slide. This might be my last breakout here. This is gender. Men and women have very similar per member per month spend. Interestingly, though, it's kind of distributed differently. So on average, 58% of our utilization is female, 42% is male, but cost per visit is typically about 23% higher for men than women in the Medicaid population. So it's just kind of distributed kind of a little bit differently. I think that's probably what you'll find in the commercial markets as well. And then the growth is pretty consistent across both genders, 5% year-over-year for females, 6% year-over-year for males, again, driven by cost of service and just very small increases to utilization. Next slide. So I have 2 slides in here that are really intended to try to summarize all the information that I've gone over. I don't know that I need to go through this in a ton of detail, but I'll just orient you to this slide and then also the next slide. The idea is that all of these numbers are from the presentation, but here you can just kind of look and get a snapshot. You know, you might be able to say, okay, I can see fee for service grew by 6%. What is it driven by? The boxes below tell you it's driven by age blind and disabled, and spend per utilizer, which increased by 5%. Managed care increased by 9%, and you could just see the distribution of the increases in spend per utilizer versus utilization. One thing I did just want to let you guys know that mathematically there's not a one-to-one relationship between like the 9% in the MCO growth and the 8% for utilization and 6%, I'm sorry, 6% for utilization and 8% for spend per utilizer. So you can't, because we didn't normalize our utilization to our membership, you can't like take those and multiply them together and mathematically back into the total. So don't get confused that they don't add up in any kind of really direct way. It really is to just draw your attention to what's driving costs. So the next slide is a very similar graphic, but talks about geography and demographics. So again, here you would be able to see, oh, the North has 8% year-over-year growth. That's the highest. What's it driven by? It's driven by a 13% year-over-year increase in spend per utilizer. And so there's not a box for utilization there because utilization is not driving that cost growth. So the intention here again is to kind of bring you along that story and allow you to kind of summarize it in a thoughtful way. Let's see, do I have another slide? I don't think I do. Oh, I do. Future considerations and just recurring themes. I think I've said this throughout the presentation, but, and then I'll get to Beth and Flo, but cost per utilizer or unit cost is found to drive cost growth across all of the segments of the population for Nevada Medicaid. We do sometimes see increases of utilization. Primarily, we think those are driven by increases in enrollment. That is a flaw in our analysis today, is that we need to normalize our utilization trends to enrollment. And so that'll come out in our next phase of this analysis. The first time we do things, it's not quite as good as what we'll build over the years. So we're going to do that next. A future consideration, I've said this before, but utilization as it returns to normal, compounding with the higher spend per unit, whether it be per utilizer or per visit, is probably going to compound into higher cost growth, I would say, in the next phase of this analysis. So just kind of have that in mind. And then we do need to jump in on health conditions, which I know Tiffany, you brought up, and then also case mix, service mix, intensity. Those are gaps in this analysis that we will drill down into for phase 2. And that is the end of my presentation. Beth and Flo, I don't know who was first.
Sorry, so I just have a couple clarifying questions, especially in terms of the pharmacy data. The first question is the data and the percentages are all based on retail pharmacy claims, correct? There's no medical pharmacy that's included in the data.
No, we actually did include medical pharmacy as well.
Okay, so it's all lumped together.
Correct.
So that could be some of the explanation, especially for that large jump. Remember, during that time period, we did have Zolgensma come out, the most expensive drug on the market. And I do know that Medicaid had at least one claim for that at $2.5 million. So that could be some of the reasoning during that time period, along with an increase in a lot of the prices in the drugs. I think more than half of the drugs paid for through Part D increased greater than inflation during that period. So I think there was a lot of jumps in terms of drug cost. My other question is around rebates. I know at the beginning of the presentation, Flo had asked about rebates, and you had commented that you included an estimated calculation. So I'm just curious what that calculation was, or how that was incorporated into the data in terms of the outcomes.
Yeah, so I want to follow up with you, Dr. Slimowitz, with more detail, but we worked closely with David Olson in the pharmacy unit and Medicaid to come up with the best way to, it is an estimate because I think we don't have the exact level of detail that we need. So I know it had to do with taking it as a percentage off the top of those calculations. We originally did our analysis without rebates being considered, and we got feedback that we needed to take them into consideration because it does change kind of the overall picture for pharmacy. But I can follow up with you on exact calculations on how that was done.
Great, thank you.
And just, Kyra, I'd love to see that as well. My other question that I had with it was on the slide back where you showed the MCO growth at 9%. I have a question on that in terms of, does the state get claims level data from the MCOs?
Yes.
It does. Okay. And the only reason why I ask about that is there's often the supplemental rebates that are paid to the MCO. Do you have access to see what those rebates in the aggregate are looking like?
I think I would have to follow up on that as well, but we as an agency, I believe we do. The MCO information in this presentation is exclusively based on claims. So this is the cost growth that the MCOs are experiencing. So just to clarify that, this is not cost growth in state spend on capitated payments to managed care organizations to cover these members. This is cost growth in the actual healthcare delivery based on the claims data that they submit to the Medicaid data warehouse.
Okay, so it's not the capitated rate. It
is not the capitated rate, no. We would not be able to break down a capitated rate into things like, service delivery, because it's not really distributed like that. So this is exclusive. This is the cost growth experienced by the managed care organizations.
Okay, so it could potentially not be inclusive then of the supplemental rebates that they receive.
I would like to follow up, but I do not think it would be, because that would not be, with the exception of pharmacy. Pharmacy is the only area where we had feedback that said it paints an entirely different picture if we don't take into account these rebates. And so we went in off the top and took those into account. That's the only area where we made kind of adjustments outside of the claims analysis.
Okay. All right. Thank you.
Batt.
I do think this whole conversation, thank you, speaks to the problem with not being able to have transparency in the pharmaceutical industry on things like rebates. So, if we're having to guess where they are or guess in the aggregate how much they matter, it's impossible to do good strategic planning. And we have the same problem in our fund, where we can get sort of a global picture of the rebates. But if they're a big piece of the market, but you can't see what they are specifically by drug, you can't make good decisions about healthcare cost management. So I think this conversation kind of shows the problem with the lack of transparency that the pharmaceutical industry protects.
But you can't have those rebates being publicly, despite you can share those with the state, you just can't have them publicly released.
The state doesn't seem to even have them. So
I think they do, though. I mean, if you get the data, I mean, they probably have a general, maybe not on a specific claims basis, but you probably have.
And I believe, and we shouldn't get into this here, but I believe the fact that the position of the industry is you can't release these rebates publicly is like the thing that should be challenged, because that's a blanket statement made, and the market can't work if there's not transparency in it.
It will skew the market if those are released, but we can debate this all day, and that's not the point we want to get into here, but.
Right.
Maybe if that's important to either one of the commissioners, then we can put it as a subject item in the next meeting if that is appropriate. Babette, would you like to have that considered at a meeting?
Sure. I don't know if it needs to be the next meeting, but I think how to present pharmaceutical data accurately and transparently would be wonderful. That'd be a wonderful improvement.
All right, so keep that in mind, please, for our future meeting, one of the future meetings. All right, moving along.
And that concludes my presentation. So I don't know if I'm handing it back over.
Okay.
To
Any further questions? Well, the timing was very good. I appreciate that. Let's move on to our next item on the agenda, number 7, review and discussion of findings of Public Employees Benefits Program, PEBP, Phase 1 cost driver analyses. Laura Rich, Executive Officer, PEBP, Tim Zettinger, and Colleen Huber, AON. Is this team here now?
We are, Chair, and I'm Laura Rich, the Executive Officer of PEB. I will be passing this off to Tim and Colleen, who represent Aon. They are our actuarial consultants who performed this analysis and are the subject matter experts. So I'm going to pass it to them.
I would appreciate if you respect the time, just like other people, so that would be helpful for all of us. Thank you.
Yeah, thanks for passing this over. So we'll jump into what we've seen on the commercial side for PEB. Again, there might be a few differences between the commercial population compared to the Medicaid population. Just some differences in how we're viewing data versus they are, which we can discuss going through. So the data and methodology that we use to complete our analysis, we use data warehouse claims from HealthScope for medical and RX, or medical and membership. We utilize RX claims from ESI, and we do not have RX rebates included in this analysis currently, so it's gross RX claims. Total claims represent PEB's liability, so employer paid claims. We actually, due to limitation in the data warehouse, we do not have 2016 claims currently, so we're using claims from March 2017 through December of 2020. The data warehouse only stores about 5 years of data currently. Our utilizer counts are based on monthly utilization and aggregated by year. And then geographic locations are in the same line as Medicaid population, with north-south rural, with a fourth population of outside Nevada. And then the same county mappings that we saw for Medicaid. You can flip to the next slide. So the first thing we'll jump into is that per member per month spend by benefit types. So what we've seen, we have broken out by medical, RX, and then combined med RX. What we've seen is medical claim costs have increased on average in the commercial population about 6% per year, which is around what our expectations are in the health place marketplace. Now this has varied year over year. So for instance, 2018, we saw a large growth rate of about 16%, leveled out to about 8%. And then in 2020, we saw the same negative 6% that we saw for a majority of our clients. RX claims have seen higher trends, again, as that gross RX rate has increased year over year, on average of about 16% per year. One thing to mention on that 2018% trend rate is that there was a new population that came into play for PEB in 2018, which is the EPO population. This population has a richer benefit design, carries riskier employees, so kind of contributes to that trend that we're seeing, and something to note. 2020 specifically, we want to talk about the negative 6% we saw in medical, which is commonplace that we saw in the market. But that same decrease we do not see on the pharmacy side. People might have given up their elective surgeries and going to see the doctor, but pharmacy claims still maintained at a steady rate, with people fulfilling their prescriptions through retail as well as mail order pharmacies. Any questions here? We can move on to the next slide. So on this slide, we try to break out what we saw between those plan types. So as previously mentioned, there's two populations for PEB, the high deductible plan and then the EPO. EPO came into play in 2018. So we have 3 years of experience for them and 4 years for the high deductible plan. The high deductible plan saw about an average year-over-year increase of about 2% from 2017 to 2020, while the EPO trended at about 4% on average over those years. As you'll see in the graph, that EPO plan, like we talked about, is just a higher cost plan. Richer benefit design, so the employer is going to pay more percentage of claims. And also this is a riskier population. So people that will utilize their benefits at a higher rate, which we'll see in later slides, just on utilization data, and their spend per utilizer will be higher. In 2020, specifically, we want to talk about the high deductible plan saw that negative 6% decrease we saw in the marketplace. However, the EPO actually saw a trend increase of about 8%. So again, this conformed to that higher risk population, still utilizing their benefits, not foregoing elective surgeries, but continuing their routine care because they have conditions that need to see providers. We can flip to the next slide. So on these slides, we'll talk about the utilization that we saw between the different plans, high deductible plan and the EPO. Specifically for percent of utilizers, we saw the high deductible plan have about 30% on average of monthly utilizers compared to about 42% for the EPO. So again, higher utilization in that EPO plan. The other thing is that spend per utilizer trend, normalizing in each specific plan, we see spend per utilizer relatively flat between them. So 1% on average for the HDHP and 2% on average for the EPO. However, we did see the EPO spend per utilizer increase significantly from 2019 to 2020 of about 13%. So utilization might have maintained, but healthier or riskier conditions, more costly conditions could have been driving this increase that we saw for the EPO plan. Again, we saw visits for the high deductible plan decrease about 5% compared to the EPO, which only saw a decrease of about 2%.
Can I ask a question here in
Sure.
terms of utilization between the high deductible plan and the basically, isn't an EPO just like a PPO plan in some respects?
Yep, it's a little bit of a narrow network. You can only go to select. There is no out-of-network care for them, so only in-network.
So question on utilization would be with a high deductible health plan, obviously you're going to have to come out of pocket pretty significantly on the front end before you utilize care. Is that driving down, that cost impact? Is that what's driving down the utilization so that's less in some respects than if it's just readily available?
Yes, that is something that comes into play, that induced utilization from the plan design. All the visits on the right-hand side include all member visits, but the number of visits that the plan actually pays for in that medical claim column, the high deductible plan will have a higher percentage of employees paying, their out-of-pocket costs before they meet their deductible and their out-of-pocket maximums.
Right.
So,
and so
exactly.
The other question I have on that in terms of the utilization then is there a way to evaluate, is that having an impact? Is it having an impact on quality of care so that people aren't actually getting the services they need on the front end, but then maybe, I don't know if it is or not, are you seeing any impacts later that we're having higher cost as a result of them not getting that care earlier?
So that's a great question, and something that has come to light in recent years with the introduction of high deductible plans is, are we just front loading costs to the employees and then are they getting a riskier population? Are their conditions progressing worse because they're avoiding care? It's not something that we've quantified in this analysis currently. And speaking qualitatively, yes, it could be something going on in the marketplace and why people have moved away from those high deductible health plans a little bit and gone more towards, cost-efficient care and, more member intervention. So you're not just pushing off those claim costs to later in, 5 years or so by people getting, sicker over time.
I do also want to add that in PEB, we offer HSA contributions. And every year that changes. And so something that's not captured in this is our plan design. With Medicaid, your benefits are fairly stable year to year. Whereas in PEB, because of budgetary limitations, our plan design changes year over year. And so there could have been, 1 year we could have been offering $700 towards an HSA contribution, whereas another year we're only offering $300, right? So that makes a difference in utilization, because that HSA money obviously is dollars that can be spent towards your deductible to help out, that deductible. Additionally, we've moved the deductible up and down, right? And so those years where that deductible is higher, is definitely, you're seeing more out-of-pocket costs for members, which could drive down that utilization as well. So there are factors here that are not captured in the utilization, and really it's plan design.
Thank you. Any other questions so we can move along?
Yeah, just to clarify, this is Tyler Winkler, that this data is inclusive of the member cost sharing. So when we're talking about cost growth, it would include those deductibles and everything.
So that is an area of refinement that we could get to. We are only looking at PEB's liability. So what is PEB paying for their employees right now? We do not have member cost share in here right now, but we could add that in the future.
Okay.
I think that's similar to the other plans that we were talking about earlier. Okay, please go ahead.
Okay. We also have our RX utilization breakout here. So we've evaluated it separately. In terms of total monthly utilizers of RX benefits, we see about 30 to 35% of RX utilizer. We have seen spend per utilizer increase at a pretty large rate, so 19% per year, as RX claim costs has increased as a gross aspect, as well as higher cost drugs and specialty coming onto the plan as a result of that EPO plan being brought to a self-funded status as well. As we talked about, the RX claims were not impacted by COVID-19, so that spend per utilizer really signifies cost growth in the RX space.
And I just want to clarify, Tim, on this, because you mentioned it at the front end, that this does not include, the rebate discussion again, which could have a significant impact on bringing down that 19% cost.
Exactly. RX rebates have grown, as a percentage of total costs in recent years. So adding that would probably be beneficial. But currently we just looked at gross RX claim costs rather than including RX rebates. So we could break things out rather than estimating.
Of course. Thank you.
Yep. So the next slide we have broken down by geography. So similar to the Medicaid population for North, South, rural, and then that fourth population of outside Nevada. Biggest takeaways here are the South region is the lowest cost region on a PMPM basis. The outside of Nevada has really been the highest cost, which really can grow to, the network choice in outside of Nevada versus what the Nevada population has. The North region is the fastest growing as a rate for total cost. So they've had an average of about 13% year over year trend compared to about 2% for the South region, 8% for rural, and then 3% for outside of Nevada. So real signifying this growth is in 2020, the North region had about 70% higher PMPM costs than the South region, which are your two largest groups, compared to 25% higher in 2017. So their growth differential in terms of cost is growing as we see. So there's a wider split there. Speaking of the outside of Nevada, this is the highest cost group on a PMPM basis, but only accounts for about 10%, 9% of total medical claims from 2017 to 2020. And that large bar that you see for their 2019 of 949 PMPM, this is largely driven by some high cost claimants that we saw in 2019. So their large decrease from 2019 to 2020 is a result of those high cost claimants not being in each consecutive year.
So quick question there, the out of state cost, do you have any breakdown whether these are just people traveling outside and ended up being sick versus there are people who have moved and are living there and still entitled to benefits without having any controls on access to care?
We actually have not analyzed that. Could be something that I can take back with us and follow up with the group.
And I can
Because
just add I can
the
add a little bit to that where, so we cover retirees as well. We have retirees in all 50 states as well as in other countries. And so without doing the analysis, I can say that there's likely, retirees are higher cost to begin with. These are not active employees that are seeking care outside of Nevada, unless, as Tim mentioned, it is, and the chair mentioned that it is people that are accessing care outside of Nevada because those services are not available in Nevada. So that can definitely be the case. Those high cost claimants, right, are likely accessing care outside of Nevada as well. So we can definitely drill into that for sure.
Yeah, could you please, because outside of Nevada, if there's tertiary level care, one could still have some control over that by negotiating rates with those facilities or services out of state. It still will not be necessarily what you're reimbursing locally. It may still be higher than that, but I hope that's being done on a case-by-case basis for tertiary level care.
So we have a nationwide network, and so we typically in the high deductible plan, and we now have a low deductible plan as well. We do leverage that nationwide network. But yes, there are situations where someone has to go out of network, and we do negotiate agreements there.
Okay, great, thank you. Next item.
So again, here we have some utilization breakdowns and spend per utilizer, which we'll want to spend some time on specifically. So as we mentioned, the year-over-year trend, we're seeing growth in the North region, really driven by that spend per utilizer. So their costs are growing while their visits are also growing, just it's price that's really driving this significant one. The North region utilizes benefits at a higher percentage than the rest, about 1/3, while the rest are, 1/4 to 30%. And then the rural region saw the largest decrease in visits of any group from 2019 to 20. While we saw that claim suppression, the rural group saw a larger impact of that for COVID. Moving on. So we have breakdowns by service category here as well: inpatient, outpatient, and professional. The inpatient and outpatient costs, as Michael mentioned in his introduction, hasn't grown significantly year over year. On average, about 4% for inpatient and outpatient about 3%. We did see a large increase in 2018 for inpatient claims of about 28%, which was kind of an eye-popping trend figure. One thing that we did see in 2020 specifically is those two, so hospital utilization, so inpatient and outpatient, saw the largest decrease as people forewent those surgeries in those service categories, about -12% in inpatient, -7% in outpatient. The professional spend is one area that we do see growth in your cost PMPM of about 10% on average. People still utilize those benefits in 2020. About 2% increase in total on a PMPM basis as well. Move on to the next slide. We have utilization. Specific on these service types, we've seen professional spend per utilizer grow at the largest rate, about 8% per year on average. We have seen outpatient spend per utilizer decrease on average. So a higher starting point in 2017, which is decreased in 2020. And the biggest driver of this is we see that the visits in the outpatient has grown significantly, almost 2 times the amount that we saw in 2017. So as more visits get utilized in the outpatient center, the cost per utilizer decreases. So hopefully that shows that some higher cost services are being administered in a more cost-effective way in an outpatient setting rather than professional. Other things we've seen is inpatient service spend per utilizer has increased about 5% per year. However, only 1% of your population utilizes inpatient benefits. So we do have some information on health conditions as well. So something different than what you've seen for the Medicaid population. So what we've done is we've found the 5 highest costs in terms of total claim dollars for PEB. And so these 5 health conditions are cancer, gastrointestinal disorder, cardiac disorders, MSK, and pregnancy. Now, these 5 health conditions accounted for about 41% of total medical claims from 2017 to 2020. However, none of them are specifically increasing at a large rate. So when we look at a percentage of total cost, they're not driving the cost that PEB is seeing, because the cost per utilizer in each of these categories is remaining relatively flat. The top 3 increasing cost conditions that we've seen from 2017 to 2020 were infections, hematological disorders, so blood disorders, and then mental health, which is another area that we see in a lot of different clients. Mental health conditions are increasing as a percent of cost. Those 3 conditions accounted for 13% of claims in 2020 versus 7% in 2017. So again, signifying that that is an area of cost that is growing large that could possibly be a form of intervention to create some savings.
I'm sorry, what is MSK?
Musculoskeletal disorders. So this can mean, back issues, anything that's about your joints and your skeleton system, basically.
Thank you.
Sorry, I apologize for using that abbreviation. Next, we have utilization. So I'll direct your attention here again to that bold year-over-year trend line at the bottom. So this is what I was talking about, is the growth per utilizer is really not driving cost for PEB. So for cancer, gastrointestinal, musculoskeletal, and pregnancy, we see year-over-year trend on a per utilizer basis remaining relatively flat, 1% to up to 2% for a lot of these groups. The one condition that we have seen a large increase in specifically is cardiac disorders. So an 18% year-over-year on average, which is really driven by 2017 compared to 2018. So that 2017 figure is just a really low starting point, while it's leveled out in the last 3 years, 2018 to 2019, 2020. So again, another area for possible program intervention, if we can identify people with high cardiac disorder risk, direct them to care for preventive use as well, try to locate those and reduce costs before they become high utilizers. Cool, we can move on if there's no questions. So the final 2 breakouts we have by age and gender, so demographic impacts. So similar to what you saw in the Medicaid population is what you will see in the commercial population is male and females, females cost more on a PMPM basis compared to males, but men who utilize their benefits are going to cost on an average utilizer basis more than a female. On average, these 2 groups have trended at about a similar percentage, so 8% for males and 7% for females on average. So we can jump to the next slide and we can talk about that utilization impact for these 2. So this one's for medical specific, and then we have a next slide for RX. In terms of medical, we see a higher utilization percent for females. So on average, about in 2020, we saw about 27% of males utilizing benefits and 36% of females. So females really utilize those benefits at a higher rate than men. While females only represent about 53% of total members, they represent about 60% of total utilizer and 61% of visits. So that disproportionate utilization that we talk about for demographic or by gender. And the other thing we want to mention is, men that utilize benefits specifically, they cost more than a female, but not a remarkably high on medical. So we see that they're about 4% higher in 2020 and 6% higher in 2019, which is leveled off compared to 2018, where men were about 20% higher than females. Yeah. So we have pharmacy spend. So this is where we really see a disproportionate spend per utilizer in males costing more than females. Male spend per utilizer is about 34% higher than females, and they're growing at a faster rate than females. So 22% on average versus 16% on average for females. So really just signifying that the cost difference between these two are really driven by pharmacy for spend per utilizer. And then we have age groups. So a little bit different bucketing as well from what you saw in the Medicaid population. So we've just used under 15 and then by 15-year age groups up to 60 plus. So main takeaways here are, we know age is positively correlated with spend per member. What we've seen is the negative 15% group specifically saw the largest decrease in 2020 in terms of their PMPM costs. So they saw a decrease of about 14%. And this is one area that caught our eye, could possibly indicate that children were not receiving preventative care and weren't going to see their doctors in 2020, which could be something that we see later on down the road for PEB. We did see that the 30 to 44 age group was the only group that actually had a cost increase from 2019 to 2020 of about 10%. And this is also the largest cost growing population for PEB at about 21% per year. Go to the next slide. We also have utilization statistics for each of these. In the terms of monthly utilizers, we see utilization as a percent of total members increasing as we go across. So about 20% of under 15 members utilized a benefit, all the way up to about 45% of 60 plus members. The negative 15% and the 15 to 29% just utilize benefits a lot less than what the older population does. What we've seen for spend per utilizer growth is that the largest cost, again, that 30 to 44 age group, is also the largest cost growing for spend per utilizer. So those utilizers are getting health or sicker conditions costing more as a utilizer basis. In terms of the negative 15 and 60 plus, we see kind of lower trend rates on a spend per utilizer basis. So 60 plus is really because those people are going to see their visits regularly, and they have their conditions kind of set when you're at that age. Any questions here? Otherwise, we can go on. Yep. So RX by age group, again, what we're seeing is growth rate for RX spend per utilizer is large, specifically in the younger ages. So drugs that are being utilized by people at younger ages are increasing at a higher rate versus the 60 plus population, which is about 6%. Again, utilizers increase as age increases as well. Next slide. Oh, and I think that takes me to the end of my presentation. So if anyone has any questions about the information presented, you can take them now.
I don't have questions about the information you presented per se, but I do have a question about just PEB and some of the data from the earlier years. So from 2017 to 2018, my understanding, particularly on the pharma side, was that your organization kind of did a market analysis of some of the contracting that occurred within those years, and that they found that that there were overly high administrative fees, dispensing fees, some of the other things in the contract. And so that was kind of driving up the cost in that spend category. And then they went, and there was a legislative commission that came in and placed upon them a corrective action plan to reduce some of those costs and eliminate some of those inefficiencies. And once they did that, they found that they were saving millions of dollars as a result of a change in the contracts. I'm just concerned about if we use this data, right, and looking back at that segment of time, the data could be skewed, and that it really wasn't attributed to some of the cost of like the product, but instead it was more of a contracting issue that has since been corrected. Now you're seeing some of those numbers kind of come down as a result. So and perhaps they negotiated a better rebate or whatever the issue was. So again, it's not anything directed towards you, Tim, but I think it does demonstrate we have to be very careful about the data, because there are situations where it's not just based on cost of product, but it could be part of the contractual terms and some of the other provisions within those contracts. And so I'm just a little concerned about using data that, at least from that time period, was flawed, and it could skew the potential benchmarking. So I guess, Michael, that's more directed to you than to Tim in the presentation.
Can I jump in here and just clarify some things? So every year PEB does conduct a market analysis. This is something we do regardless on our pharmacy benefit manager. And so every year there are findings. We've got Tim and Colleen and the Aon team actually do, what is called a market check, and they compare what kind of contract PEB has in comparison to the what's out there today, right? And with similarly placed clients. And so we're able every year to renegotiate that. And so that was one of the, I think that was the first year we actually did the market check. And we've been doing it ever since. So it's not flawed data, and it wasn't necessarily when you're discussing the LCB audit and the findings, that was just in general, the contracting that had been done historically at PEB. There were contract extensions and things like that. And so we did actually, I think we've done 17 RFPs in the last 2 years at PEB. And so everything has been renewed. We definitely have the new Express Scripts contract begins on July 1st and it is a much stronger contract with a lot more transparency. So we're going to be seeing probably some better pricing moving forward. But that is not to say the data was flawed or that we had poor, we had poor contracts in place. It was just that every year we do a market check. The one thing that does impact, and again, it goes back to the plan design, and I believe it was 2018, we introduced something called the preventive medication drug list. And what that did, it's a pretty extensive list of maintenance medications that are excluded from or carved out in the high deductible plan from the deductible. And so you go straight into co-insurance versus that deductible. And so that first year, so you see in 2018 that our RX costs skyrocketed. The intent there is that you're spending it on maintenance medications and encouraging compliance of those folks that need to be on a maintenance medication. For example, like asthma, right? Asthma medication is it's expensive. And so a lot of people just don't take it. And that lands them into the hospital, where then you see higher hospital costs. And so that asthma medication was on that preventive drug list. And so we saw a whole lot of utilization that year. And obviously, there's that goes into rebates and things like that, right? And as Tim said, rebates are a very significant portion of our pharmacy spend, and we've been seeing that go up every year. And every time we do a market check, we renegotiate better rebates and admin fees and things like that. And so you've been seeing year over year that we have negotiated stronger contracts through that market check. So I wouldn't say it's flawed data. It's good data, but it's other factors in plan design and things like that can really affect it.
But thank you, Laura. And I misspoke. I should not have said flawed. You are absolutely correct. And that was a mistake on my part. So forgive me for that. And you're right. I think there were other factors that played in. And I guess what I should have said is it may mislead in terms of where the spend was when you look at those other factors. And you are absolutely right. When you allow people to have access to those products without that high deductible on the front end, it does lead potentially to better outcomes and, quite honestly, less cost for not having to use those more higher cost services. So thank you for that clarification. It was very helpful.
This is Colleen. I was just going to add, I mean, AON does deem it a best practice to have a market check ability within the current PBM contract, just because these contracts tend to be a longer duration and could be 3, 5, or even longer years. So to always revisit the pricing with the PBM and the plan sponsor always makes sense to do it on an annual basis if possible, just so that the contract terms themselves don't get stale and you reduce the spread that the PBMs or outside parties can get. And then that way the plan sponsor and employer can realize the savings from that.
This is Dr. Khan, just to remind everybody about timing. How much more time do we have? Because we have at least one other major items, if not two. So how much more time do we need for your
We're running on time, Chair
Okay,
Khan. I
okay.
believe that Commissioner Bond has a question about this presentation.
All right.
No, that's okay. I think that Laura Rich did a really good job of talking about the data is the data and the reasons for the growth in our transparency needs is to be able to isolate, what was the cause. So I really appreciate the clarification. Thanks.
Any more questions for Colleen or Tim or Laura?
I'm sorry. I do. This is Chair Khan, one question, and it may have been a question on the last agenda item, but when it comes to the Medicaid dollars that are being spent and the tracking the cost, maybe Mr. Whitley can help answer this question, but is when a patient goes outside the state, is it paid at the Medicaid rate of the state of Nevada or that particular state that they're in for services provided outside the state? And are we capturing all of this in all these analyses that we're being briefed on? And these are wonderful presentations. But I was just curious if that, because perhaps that rate is different in another state, the cost may be skewed a little bit. So hopefully that's clear enough.
This is Richard Whitley. We usually are negotiating a rate when we send people out of state, and that would then be captured, but in our cost data. But it's usually negotiated because the service doesn't exist or is not adequately existing in our own state.
Thank you, Mr. Whitley. I appreciate that, and maybe once we get through some of these other initiatives that we're doing, how can we help the state of Nevada provide those services within the state so we can save some of those dollars and infuse perhaps some of those dollars and services that are not delivered in our entire state. But I appreciate it, Mr. Whitley, and we're always glad to help on that, but maybe a later agenda item for next year.
So just to follow up to Mason's question, when Medicaid patients from California and Arizona Access and Medi-Cal come to Vegas and get sick and taken care of, and Mason can add on to it. California doesn't pay forever. And when they do come back and pay, they pay what they're paying in California. And same with Arizona Access. Correct me if I'm wrong, Mason.
Chair Khan, yeah, and I can only speak for UMC, but we try to be providers for all those states because we have such a high tourism population. So we are a provider for California Medicaid or Arizona or Utah, but we often do get some other states that maybe from the Midwest or the East Coast. So depending on the account balance and the work and the time and energy to get that application approved to cover the patient's expenses, so they don't have out of pocket. But you're correct, Chair Khan. We try to provide for those other states as well. But I think, as Mr. Whitley said, perhaps a bigger global issue is how do we drive some of these costs down for the state overall and all their payers by providing that service within the state of Nevada, which has been a long issue in our state. But I think this committee should be one of those that helps address that once we get some good costing data and we're on the right path.
Thanks, Minister, and I agree.
Thank you.
So please proceed. Please proceed.
So our next, first, I want to thank the presenters, Kyra, Tim, Laura, for all the information that you all shared. You all have seen a tremendous amount of information, and the question in all of this is, so what does it mean for our work to try to improve affordability? So in advance of our next meeting, I'd like to invite you to think about what this all means, because you just saw a tremendous amount of information. But think about it in terms of where there are opportunities that you think should be prioritized, so that at our next meeting, we can begin to talk about potential cost growth mitigation strategies that are informed by the information you've seen today in terms of cost drivers. We, as staff, in preparing for the next meeting, will try to summarize what we all think are the key messages that you should take away in terms of where there are opportunities worth studying further, if not worth pursuing. But that is the purpose for all of the information that you just had presented to you. So I want to pull that back together before we move on. Any questions or comments on that?
No, it sounds reasonable from what you're saying, and I think it's a good idea personally. If other commissioners don't have any further comments, we can move on with the presentation. Or is the presentation over?
No, we have another topic. This is a topic that relates to the benchmark. So we're leaving the data use strategy. We're going back to the benchmark. It's one technical question that we want to put before you for your feedback and recommendation. Next slide, please. So the question is, for which entities should performance relative to the benchmark be publicly reported? And specifically for provider entities, which one should have their performance reported? So this is usually defined in terms of a number of attributed lives. And you can see here the standards that have been developed by a few other states. Broadly stated, they set a minimum of either 5,000 or 10,000 attributed lives. It varies based on the market. In Oregon, they actually report on total performance across markets. But the numbers you can see here for Delaware, Oregon, and Rhode Island are generally in the same ballpark. So I will say that I don't think that any of these figures were empirically derived, and we thought it would be worthwhile to have a recommendation for you that was informed by data analysis. So that's what I'm going to share with you today. Next slide. So we looked at data from 2 states that have analyzed data at the insurer level and at the large provider organization level. You can see here 6 insurers and 11 provider organizations in Connecticut, 4 insurers and 7 large provider organizations in Rhode Island, and for 3 markets, commercial, Medicare Advantage, and Medicaid. So altogether for provider level, we had 42 data points. So we looked at the confidence intervals that were created and as they varied based on the size of the population. We found that confidence intervals were reduced significantly when provider entities were at about 5,000 attributed lives. They reduced even further at about 15,000 attributed lives. When we looked at the data points, we realized that we could have more statistical certainty, or that is confidence in the finding of performance against the benchmark at 15,000, but we would lose a lot of provider entities because there are many that have attributed lives counts that are far below 15,000 by market. Okay. We did the same analysis for insurers. We had 20 data points. Here, overall, the confidence intervals were much smaller because the populations were so much bigger. Many more members for an insurer than you would have attributed patient lives for a provider entity. In general, it wasn't clear that establishing a threshold above 5,000 would much impact variation because the numbers of lives that they had were usually far in excess of that. So, next slide. We recommend the adoption of a minimum threshold of 5,000 enrolled lives for insurers or attributed lives for provider entities for public reporting of provider entities and insurers' baseline performance. I'm sorry, not for baseline performance, for their first year performance. So the first year performance will be reporting on 2022 performance in 2024. Okay, so that's our recommendation. We further recommend revisiting this recommendations once you have 2 submission years of benchmark performance data. So that would allow us just to be more informed in terms of setting what the minimum should be. Tiffany.
Do you anticipate the level of urbanicity being a challenge, particularly for the rural areas? Are there areas in Nevada, particularly our rural communities, where that benchmark will be a challenge?
On provider entities in rural communities. They just won't have enough attributed lives. We'll be able to do data use strategy analysis as you've seen today, but the benchmark measurement at the provider entity level is to hold provider entities accountable to the benchmark. And there, if the provider entities are based in a rural community, they simply won't have enough patients. Any other questions or reactions to the recommendation? Does anyone disagree with the recommendation? Tyler.
Sorry, this is Tyler, and I don't disagree with the recommendation. And then this is just the public reporting of it, right? We still get all the data in aggregate. It's just likely those rural providers aren't going to be a part of the public reporting.
Right. Yeah, because basically we could not determine with any confidence whether or not they met the benchmark. The confidence intervals, given their small populations, would be so large that we just couldn't render a judgment. That's the reason. Does that make sense?
Yeah, I think there's probably something to be teased out about just the transparency of that, because we do want to know what rural healthcare cost is.
Well, we'll be able to do that at the regional level, as you saw today. We just won't be able to say that, one provider, let's say there's a rural health center in a community and they've got 2,000 patients. We won't be able to say whether or not they manage spending growth to the benchmark, because we can't responsibly make a determination because the population is too small and there's just too much random variation at small population size. We will be able to say that for the totality of rural Nevada, what's happening in terms of per capita spending growth. But we won't be able to pick out individual providers, unless perhaps they're part of a much larger system.
Right.
So if any of you studied statistics a long time ago, I'm drawing you back to that right now. Babette?
Thank you. I just want to amplify the need to figure out what we can about this data, even if it doesn't meet confidence intervals that would make it statistically significant. And so maybe when we know more about what kind of data we're getting, or if we're collecting that from providers in the rural areas, maybe there's some analysis we can do that just compares the rural market to, in one area to the rural market in another. That's one suggestion. And even if it isn't a confidence interval issue about whether they're hitting the benchmark, we'd be able to see price trend. Is that
Yes.
going to be possible? Okay, so
Yeah,
that's
absolutely. Yeah, I want, you remember that
Yeah,
slide I
remember
showed
going
earlier
through
that was
this
split in the
before.
middle?
I remember you made me go. I think this is the third time you made me go through it, promising you
okay.
will see trend.
Yeah, when I'm talking about the benchmark, it's for total medical expense incurred by patients who are attributed to an insurer or to a provider. That's separate from the data use strategy, where we absolutely can look at what's happening to prices in rural areas. Oh, how nice. Yeah, so I'm talking about the benchmark on the left, aggregate data, the detailed analysis of what's happening in prices, because you heard today, prices are a big factor in spending growth for both Medicaid and for PEP.
Yeah.
And so the ability to understand what's going on in prices certainly, I think, should be an area of focus and might appropriately be an area for considering cost growth mitigation strategies.
Okay, I feel better. I do want to just, and if we do 5,000 as the base for a provider, do we know what percent of the federally qualified healthcare centers in urban or rural areas would be included in that? Because I think that they have their own special challenges we want to really understand.
Yeah, so we obtain data from Medicaid or from the Medicaid MCOs on providers and how many attributed lives they have. There are very few providers actually that have more than 5,000 attributed lives. So few that it actually surprised me. And so we have a list that we're going to use for the baseline benchmark analysis, which is the one that's not going to be publicly shared. I'm not convinced that we have the definitive list of provider organizations that have a lot of attributed lives. And I'm hoping that through conversations over the next year with payers that we'll come up with a more definitive list.
Okay, and if we reduce the threshold from 5,000 to 2,000, then the confidence intervals get so big that we're not measuring anything reliable.
Well, we would just look at it and we would say, okay, it looks like their spending growth rate was, I'm going to make this up, was 5%. But that's going to be potential. The confidence interval might say, well, 5%, but it could be 35%. Okay, so if that's your level of precision, then you really can't render any judgment. That's why we need to set a minimum. Does that make sense?
Mm-hmm. It does, as long as we can see the raw data or patterns in the data separately from the confidence interval issue, which is showing the data use strategy is going to be so much more important than I realized early on.
Right. Right. And you just got a little introduction to it today in those two presentations you saw. Okay, and it's why I'm encouraging all of you to go back and look at those slides and identify if there are any nuggets that you think we need to focus upon. And you did hear at different points, both Kyra and Tim calling out specific points for your attention, but we want to grab onto those key observations, because that's going to inform the types of strategies that we want to consider for improving affordability. Okay, so let me wrap up and then we can move on to the next agenda item in terms of next steps. For the benchmark, in only a few weeks, we are going to, or the state's going to formally request the baseline data be submitted by payers. This will be by Medicaid MCOs, by commercial insurers, for all their lines of business, for Medicare fee-for-service, and from Medicaid fee-for-service. There'll be a training for payers about the data submission. They'll be asked to submit data this summer. And then by the winter, we will share with all of you the baseline findings. Okay, so that's what's up on the benchmark analysis. It's about to kick off. In terms of the data use strategy and the cost driver analysis, well, you saw a presentation today. We're going to think about which phase 2 analyses should start following this, and we'll want to update the phase 1 analysis with 2021 data after the claims run out is complete, which will be in a few months. Okay, and then finally, we're going to talk in our next meeting about both cost growth mitigation strategies, and we're going to talk about your 3 bills. And of course, the 3 bills can include cost growth mitigation strategies, although we are only just beginning to have that conversation. So we're really going to work from the ideas that you've already submitted, and we're going to ask you to try to help whittle down all those ideas so that we've got 3 to advance for the next legislative session. All right, so that's what's on the agenda. The advisory subcommittee is meeting again. Their last meeting was canceled because they didn't have a quorum. Hopefully they will for the next meeting. And we'll talk about, again, the bills and cost growth mitigation strategies at our next meeting. So that's it, Chair Khan, for this agenda item.
Thank you very much. I really appreciate your awareness of our time limits. So that's very helpful. All right, moving along. Our next agenda item. Leslie, you want to start that off?
Sure. Our next agenda item is discussion and possible approval of the amendment of our commission bylaws. Everybody has been sent the 2 suggested amendments. And I believe that Commissioner Bond has withdrawn hers, but I'm going to kick this over to our executive director, Melinda Southard, to take care of this portion of the meeting.
Thank you. So before we get Madeline on to talk about it, I think the staff did an excellent job. Leslie, you were also there, and our new executive director came in to share the basic bylaws and then receive everybody's changes. I believe everybody's suggested changes, if they were appropriate and legally not of any consequence adversely, have been incorporated in the suggested bylaws today. So if anyone has any new thoughts or ideas that have dawned on you between your last input and now, you can please share it with us. Otherwise, we can proceed with adopting the bylaws unless somebody has additional items or wants to discuss a particular item that we are not fully in agreement with. So it's open to the commissioners.
Batt, I see you have your hand raised.
Thank you. Yes, thank you, Leslie, for getting us through this process. It was really good to see that there was other input besides mine to these bylaws. And I appreciate, so my understanding of the process right now is we have approved bylaws because we approved them in a previous meeting, but then we also wanted to be able to review them and add changes to them and edit. And so you got input from me and you got input from one other commissioner. And when I saw yesterday the comparison of both documents, my input compared to the other commissioners, I can just take my input off the table because it's very similar and it captures the concern I had that the trustees at least have to show, the commissioners have to show when there is a conflict, which didn't exist in the previous document. So I'm good. And just in the interest of simplicity, the document that y'all have that starts with bond, I just don't think that we need to hash through that. I think it would be great to spend our time focusing on the other.
I agree. I like that comment, Barbara. I agree with that. Any commissioners have any comments? Because this is for possible action today. We can, if not, we can proceed with voting on this as presented. Is there a motion to approve?
Commissioner Khan, I just had a question. It was more clarifying. I saw that in the set of amendments that we removed the provision that you had to have a majority of those present to support any kind of action, and instead it was by consensus. Can you just clarify for me what does that actually mean? So it's consensus. Does everyone have to agree? Because then I noticed it says that the minority would be noted in the record. So what does consensus mean in terms of the bylaws?
Really, it's the majority that is agreed upon. That's what it means. The minority would be recorded, which means those not in support of it, it will be a part of record. The so-and so commissioners were not a part of this decision.
Okay, so then why was that line stricken?
So Leslie, you want to comment, or Manlin?
It was suggested to us, Michael Baylett suggested it to us because it was confusing as to what was written previous to that. So Michael, maybe you would like to explain that portion. And then also after you do that, we wanted to give Commissioner Winkler a minute to explain his amendment.
Sure, thank you.
Sure. Yeah. Thanks for your question, Flo. So my suggestion, based on experience with like bodies, is that it's ideal that a body like this tries to come to consensus, meaning that you all agree on something, and that if in the end you can't, that only then you go to a vote. But that your first step is to try to all come to agreement as a body, and the vote is only if you can't achieve that.
Right, so I think that's a given. That's a given. If the consensus is not reached, obviously there'll be a vote. I mean, if everybody's silent, that means silent approval, that's consensus. But if somebody raises their hand, I don't think it's a good idea, then obviously it'll be voted on, and the majority vote prevails, and the minority's vote is recorded as having been opposed. Does that answer your question?
Yes, thank you.
Okay. All right, sure. So who else do we have yet? Mr. Winkler wanted to say something?
So it was requested of me because I worked on an amendment with Leslie, and what we primarily added was AB 348 add an additional requirement that members of the commission shall comply with requirements of NRS 281A 420, and that is all the Nevada ethics laws, conflict of interest regulation. So I just condensed that information and put it into our bylaws that explains it. And then we've also included a conflict of interest form. I was looking at other boards under DHHS, and they make use of a similar form that just, it has a list. You can put who you're employed by, any possible conflict of interest. So that way that's just public record and available to everyone. I thought that was really simple and in line with what AB 348 was wanting.
So I think Batt talked about it earlier. If there is a conflict of interest, for example, I know the commission, Clark County Commission, and Batt would know better. They vote on a particular issue. If any commissioner has a conflict of interest on that issue or is associated with an industry on which the vote is being taken, they declare their conflict that I am employed by so-and-so, etc., and just make everybody aware, and then they proceed with the vote. Now, there are two things floating around the country, as I know, is in some areas they can declare the conflict and still vote. In some other committees, commissions, boards, they declare their conflict and not vote on that issue. So any other thoughts of other commissioners? Which way we should be going, declare the conflict and not vote, or declare the conflict and still vote as long as the public is aware that the person was in that industry?
Well, our bylaws are explicit that they would not be able to vote, and that.
Correct. So I was coming to that because I just wanted everybody to know there are some boards nationally that allow the person to vote, and in our situation, not to vote. So is that everybody's understanding?
Yes,
right.
I would support that.
Right, and I would support that also. So as long as a person declares a conflict, then that person doesn't vote. Any other thoughts on that?
Chairman, the other reason I think that's particularly important in this commission is we have people on the board that don't fill the slots that are appointed in the law. So I think that's what generated this extra level of caution, so that there would be some clarity around where conflicts might be that don't exist in some other committees or commissions.
Yeah, so
but Bobette, I'd like to know who doesn't fill a slot on the board or appropriate slot on the board?
Well, your slot, there's no pharmaceutical representative on the commission anymore, and you're a pharmaceutical representative filling a public slot.
Yes, I was appointed by the governor to fill this slot as a public member with expertise.
Right.
But I mean, that was
exactly
the governor's decision to fill that slot as me as the public person.
Exactly.
Okay.
So I think what Bob
is that a conflict?
I think it's a conflict if you're representing the public in a pharma vote. I do. So I think that this will be good for us to see.
Well, I think the conflict of interest provisions are dictated that there's a personal benefit to a particular industry or whatnot. I don't think there's any particular benefit that is attributed to that. It's knowledge based. So I don't think there'd be a conflict.
I'm not sure what's knowledge based, but I appreciate these being brought here, and I appreciate the vote.
So I'm glad you brought it up. So my understanding is, if a person is engaged in any way, shape, or form with an industry or employer or whatever else, and there's a vote relevant to that industry, irrespective of which slot one is filling in, then that person should not be voting on that industry's vote, subject to that industry. That's my understanding. So even though the person has been appointed as a public member, so if a doctor is appointed as a public member, but he's still a doctor and it affects the practices of doctor, if it is going to directly impact him or her, then that person would abstain. And any other comments from committee?
That's my understanding as well. I'm sorry to interrupt you. That's
what no.
I think you can present a point of view without having it directly, even though it impacts a certain industry, you can do it on behalf of the public because you're arguing that it's not in the public's best interest.
So I think we'll probably get clarity by our legal counsel. That'll be the simplest thing to get it clarified so that we are doing it right by the law. So do we have our AG's representation? I don't think so.
Yes, you do.
Oh, yes. What is your thought? What is your thought on this?
Well, this is Suzanne Sleva from the AG's office, and that, you know, the whole conflict of interest issue, unfortunately, is not completely cut and dried. I mean, yeah, it's very, very clear if a member would be getting some kind of direct financial benefit or potential financial benefit from an item to be voted on. That is a very, very clear conflict of interest. However, more subtle issues often involve, and we use this term in the legal world a lot, the appearance of impropriety or the appearance of a conflict. My advice would be for any of the commissioners, if it would appear to be a conflict, then my advice would be to abstain from the vote. Now, I understand that's the very, very conservative, very safe route. And as your legal counsel, that's what I'm pretty much always going to advocate. But I as far as, what a conflict of interest is, I think a lot of that's got to be taken on a case-by-case basis. Like I said, there are some conflicts that are very, very clear, but a lot of them are not.
So what should we put in our bylaws? You are the boss. language wise? How
If
do
I
we?
could, is there a possibility to display the relevant amendments? Because we're kind of talking obliquely about it, but the amendments are very explicit. We've actually spelled out everything in it, and included a form that you can fill out that'll list all your conflicts, possible conflicts.
Everybody's been sent this document numerous times in the last couple weeks. If you would like to read the language that you wanted to add,
Sure,
I would encourage
that
you
would
to
be
do so.
easiest. Yeah, so
And then everyone can decide if they want to vote on this or they want to pass.
So the paragraph that's added is, in accordance with Nevada ethics laws, a member shall not approve, disapprove, vote, abstain from voting, or otherwise act upon a matter without proper public disclosure of any conflicts of interest. A member shall not vote upon or advocate the passage or failure of, but may otherwise participate in the consideration of, a matter with respect to which the independence of judgment of a reasonable person in the public officer's situation would be materially affected. The chairperson or a majority of the commission members may also declare a conflict of interest exists for a member and ask that the member be removed from the voting process. Accordingly, each voting member shall sign a conflict of interest form provided by the Department of Health and Human Services and updated as needed. That's the added language.
So conflict of interest, to the point earlier raised is, and the point raised by the AG's office, appearance of, if, for example, there are people around who may be on various groups, just say on a board or otherwise, and not financially benefiting from that entity or group or what have you. So, and they still, out of abundance of caution, declare conflict of interest, even though the person is not directly financially benefiting from this. And that's why I asked the AG to elaborate. Does that mean a person is not directly financially impacted? Then it's not a conflict. But if a person is directly financially or in kind, money or in kind benefit, then that person should abstain. Is that the correct understanding that I have?
And this is Suzanne Sleva again. Yeah, yes, I think so. There may be other conflicts that are not as clear, and that language, I think, is addressed in the paragraph that Commissioner Winkler just read into the record. If there is a conflict about whether something is a conflict, that is something that can be addressed either by the chair or the majority of the commissioners.
So as you said earlier, that's on a case-by-case basis,
yes,
rather than a broad form that everybody's out of abundance of caution putting down in the form a million things, which really may have no benefit or consequence personal to that person.
Well,
so
I
on
don't,
a case basis.
I don't know that there are, you know, that there's quite as much information on that form as, I don't think there's a lot of extraneous information on that form is what I am trying to say. In looking at the form that was submitted by Commissioner Winkler, it says, please list any of the following affiliations: employers, boards or commissions, allegiance or financial interest you or any member of your immediate family has that might affect, you know, might affect or appear to compete with your duties on the PPC. And those are things that can be disclosed up front, but they can also be added to if something comes along. And I know that everybody on this commission, you know, cares about what the commission does, cares about what you're tasked to do, and are interested in doing it with integrity. So if something came up that would appear to be a conflict or that a commissioner feels would be a conflict, I think that either the form could be amended or it could be brought up in a meeting. And I see somebody's got their hand up.
Hi.
Go ahead.
Chair Khan, and thank you, Suzanne. This is Mason Van Houweling. I think we probably need to take a step back a little bit, because I know when we all took the oath of office and filled all of our documents, we did say that we're going to uphold the Department of Ethics and the state of Nevada's ethics. So I don't want to, I'm a real big person on not recreating the wheel. And I think even just from experience of being at UMC for 8 years, our board is a public board, and we actually have a gentleman every year that from the state, and his name eludes me, but does a presentation on ethics and conflict of interest and voting. So I just don't want us to create a new set of rules that may have different language than the state's rules. I'm all about disclosure, and I got my form, and I'm going to be faxing it back right away. And I think many of you know that I'm on a lot of hospital associations, but I agree, we're all experienced, and that's why we're all here. We should all have an opportunity to say what we need to say. But then also, I always say if there's a personal benefit, that you need to disclose that and then not vote. So, but I just would, with Suzanne, I know there's a gentleman this is his sole job of ethics at the state of Nevada. And I know that when we took the oath that we sworn to upheld that. And so maybe that's where we need to just reference versus trying to create our own words, because many people have worked on this for 50 plus years. So just my thoughts.
And
Thanks,
that
Ms.
makes a lot of sense.
My hand up for a time. May I speak?
Yes, please.
I'm sorry, I think I'm getting lost in some of the sensitivities and want to make sure that I understand what the potential vote is. And so as a clarifying question, are we merely voting on the fact that we will commit to actively managing any conflicts of interest, whether it's financial or the perception of it? And are we committing to honoring the statute set forth by the Ethics Commission? Is it a vote about will we honor those two things?
Yes, that is exactly it, Commissioner. Thank you.
But it's not a vote on that. It's a vote on including the statute in our bylaws, because we're already held to those ethics requirements. We're just putting it in our bylaws. And the language is literally just from the statute put into our bylaws. That's all it is.
So should we just mention that rather than rewrite that all over again in our bylaws and just reference that, and that takes care of it? Reference the statute, reference the Ethics Commission.
Chair Khan, I don't see what the conflict, I don't see what the problem is here. I don't understand why there's pushback on this. I feel like if we all are doing the best we can as commissioners, and I was witness to what I think were some conflicts last year, and this is a simple fix that's already in state statute. I don't understand why it's a hard thing to vote on.
I don't either. I don't understand. And this is fine. Like, I have no issue with this.
So anybody else has issue with the language to narrow down our discussion?
No, as Commissioner Tyler Winkler mentioned, if it's verbatim, I think we just need to make a motion and.
Yeah, I agree.
Yeah.
So let's have a motion and a second, and if there's more discussion, we'll have it. Anybody who would like to make a motion?
Motion to approve.
Okay, is there a second?
Second.
Okay, any further conversation on this before we take a vote? We have had enough already, I think. Okay, so Leslie, you want to count, or this is quote unquote by consensus? So we just talked about consensus. So any opposed to this language being incorporated? Please raise your hand. Do you see any hands up, Leslie? I don't on my screen.
I do not.
Okay,
Melinda,
so
do you see
basically
any?
it's approved by consensus then, right? So let's move on. So we'll wrap up this subject of bylaws. So we're getting close. So this was item number 9. Item number 10, any public comments, north, south, east, west? None. Any written comments presented or information by anybody, Leslie?
I do not see anybody raising their hand for public comment.
Okay, so that takes
do
care
not
of
have
item
anything.
number 10. And I really want to thank everybody for being so efficient. I love that we are finishing half an hour plus before so everybody can go to their normal business. So I would call it for an adjournment unless somebody else wants to carry on. So we stand adjourned. Thank you, everybody.
Bye,
Again.
everyone.
Really appreciate
Bye,
time.
thank you.
See ya.
Thank you, everybody. Appreciate
Bye.
your attendance and input.